right, so I will turn to an older trial. So again, so the ProFiDys trial was designed in the middle of the years 2000, and we have already presented the data regarding the study one, because there are two studies, and after discussions with some of the authors, we have decided not to publish the first part before having analyzed the second part, probably to build a single paper. And so this is again a double-blind randomized placebo-controlled trial. So the background was that bisphosphonates have been widely used in the treatment of fibrous dysplasia to treat bone pain for more than 20 years. And we have positive results from uncontrolled studies using the IV drugs. And so their use initially have been advocated to reduce bone pain, improve bone strength, imaging aspects. And also in the 1990s, when they started using them, the bisphosphonate doses were comparable to those used in the treatment of pagesthesis of bone, which is why we chose the 30 milligram risedronate dose in courses of 2 months rather than the usual osteoporosis drug. Also, there was a randomized placebo-controlled trial comparing a lesionate placebo that was conducted here at the NIH that did not show a significant effect on bone pain and imaging, but there was a reduction in bone turnover. So we wanted to test the value of another bisphosphonate, which is probably comparable in terms of potency with the lesionate, with different design, different types of patients, sort of different indications. And so we wanted to answer two main research questions. One was, does risedronate reduce the level of bone pain? And so this is ProFiDys 1 that has already been presented, and basically we observed a 40% decrease in bone pain in the placebo group and 40% in the risedronate group. And the second question was, does risedronate improve the radiological aspect of bone lesions? And this is what I'm going to talk about today. So, eligible patients, of course, had no contraindication to risedronate, essentially severe renal failure. They were bisphosphonate naive, and of course, consented to participate. So, study 1, patients who have bone pain, and 32 patients who did not have bone pain. It's probably, but had osteolytic lesions. And as we wanted to treat them for several years, we did not want them to have bone pain at the baseline for obvious ethical reasons. We did not want to leave them on placebo for 3 years. So, asymptomatic osteolytic lesions, randomized to receive risedronate or placebo for 3 years. So this is the kind of cycle: 2 months of risedronate, 4 months off, 2 months of risedronate over 3 years. Everyone was on calcium plus vitamin D, and those who had renal phosphate wasting could also receive phosphate plus calcitriol. And they were monitored specifically in this case. So the inclusion criteria was to have at least one measurable osteolytic lesion using computerized tomography. And non-inclusion criteria were other metabolic bone diseases, ongoing malignancy, history of the Fibrous, CKD, severe hepatic disease, history of uveitis, untreated rickets or osteomalacia, allergy to bisphosphonates, prior use of bisphosphonate or fluoride, pregnancy and breastfeeding. Very classical. A number of visits, so at inclusion, of course, 1 month sort of motivation visit to improve the retention of the trial, 6 months, and every 6 months thereafter, phone calls every 3 months, and CT at the baseline for a sort of index lesion, and 3 years or end of the study if the patient wanted to drop out the study earlier. So the primary endpoint, that's the radiological improvement, and we built a semi-quantitative index to look at this, and we'll get into greater detail. Secondary endpoint, change in quality of life, FF36, change in bone turnover, and BMD changes if there's an affected hip. So today I will report only the primary endpoint. So this is the way we quantified the change. So 0, that's no change. 1, that's uncertain change. 2, that's small change but certain. And 3, that's certain and important. And so in the analysis, we have coded no change and uncertain change as no change. So that's 0 in the database, and 2 and 3 were also lumped together. Okay. So when we say no change, that's no change or also uncertain change. And when we say change, that may be small or important, but certain. Of course, there are different types of changes in the images. This can be diffuse change, improvement in the lesion. This can be only a peripheral change of the lesion. It can be irregular. It can be in sort of improved mineralization of the walls that you may observe within the lesion. This can be sort of a thickening of the cortex, recorticalization, or any other. So the randomization was centralized, blocks of 4. This is very important to have small blocks in this kind of small study to make sure that the two groups are well balanced. This was stratified by clinical centers. So the sample size was very important. The sample size was calculated on the premise that risedronate would allow for improvement in 50% of patients on risedronate, with an improvement in 10% of patients in the placebo group, alpha 0.05, beta 0.90, dropout rate 8%, so that leaves us with a sample size of 59. Fisher exact test for the primary endpoint of proportions of patients with improvement in radiological aspect. And we've done a per protocol analysis here. So the flow chart of the study, we've been able to randomize only 37 patients with FDMAS. Well, that's good for a trial on FDMAS in terms of sample size, but we are roughly at 50% of our calculated sample size. 5 patients dropped out for study, and we don't have a second CT for those, so which is why we've done a per protocol analysis. So we have 32 patients who have completed the study and have both the baseline and the end of study computerized tomography. Baseline characteristics, slightly more women than men, patients in their 40s, slightly overweight, and moderate to severe fibrous dysplasia, and something like 10% or 15% of them had maximal Barrett syndrome. Only a fifth or a quarter had a prevalent fracture. So this is the primary outcome. What you can observe is that in most patients over 3 years, nothing is visible. Okay, this is my take on this. So in the placebo group, 2 patients have improved. In the risedronate group, 2 patients have improved. And also, there was negative change. So in white patient on risedronate, there was an aggravation, actually, of the lesions. So let me show you a few images so you can understand what we are talking about. So this is a patient on risedronate. So on the left-hand side, this is the baseline before starting therapy. And if you look at the right-hand side, look at the arrow. This is the arrow sign. And you can see that there's a change, that small change. I believe that certainly have no mechanical consequences, but clearly there's something that's happening. And also, the periphery of the lesion is probably more mineralized. Maybe the surface of the lesion is smaller. Well, it's not maybe, it's mid-measured, it's smaller. But so this is what we call a small but certain change. Okay. This is again a patient on risedronate. This is the one who had actually an impairment. So on the left-hand side, you have the osteolytic lesion. And 3 years later, you can see that it's larger. And if you look at that another way, again, the lesion is larger after 3 years of therapy. And we have no reason to believe that this patient did not take the drug. Okay. So to conclude, I would say that the primary endpoint of more frequent CT improvement on risedronate compared with placebo was not met. The study is underpowered, but still, if there was something that was really substantial, we probably haven't missed it. You know? So I think that a substantial difference can be ruled out. We show anecdotal evidence that impairment on bisphosphonates, on risedronate is possible, and that natural improvement also is possible over a relatively short period of time. And also using CT as an outcome for trials, that's probably also an interesting lesson from this. Using CT as an outcome for trials is feasible. And currently, there's a group in our internal unit working on bone metastasis, and so we are developing a finite element analysis model based on CT scans of people who have osteolytic lesions, so to estimate their risk of fracture. And for a future trial in FD, we will probably apply that, because we've shown that making a qualitative or semi-quantitative analysis like this is feasible. And then this kind of images can also be used to do finite element analysis to estimate the bone strength and so the risk of fracture. And so for future trial with different drugs, I think that's an interesting outcome. And so finally, I want to acknowledge also all those who participated in the trial, the funding, so national agencies for the 3 countries who participated, so Netherlands, Belgium, and France, 4 centers, Leiden, Brussels, Paris, and Lyon, and the companies that provided the risedronate. Thank you very much for your attention.
That was very nice, thank you, and I have 2 comments. The first of which is, I'm really impressed with the fact that you, as have we, done placebo-controlled trials in fibrous dysplasia, rare disease. These are very, very challenging, and it really is going to make a difference for the patients. This was not done in osteogenesis imperfecta, and the disease is problematic because of lack of these. So hats off to you and to us for doing that. They're very hard to do. The second thing, I'm so glad you mentioned the CT and that there can be a lot more done with this. And this will be a good opportunity, I think, for collaboration as well. Allison and I are working with a group in our nuclear medicine department and CT department for in-depth and sophisticated analyses of these CT scans, and we should probably talk about that. Thank you.
Thank you.
Hi, thank you so much. I really am impressed by the trials that you're doing. The 3 patients that responded to the IL-6, anti-IL-6, what did they presumably had the drug and the placebo?
As far as I remember, 2 were on Tosi, then placebo, and 1 was on placebo, then Tosi.
And what did they look like during the placebo treatment?
The pain relapsed progressively. It did not go to the baseline, go up to the baseline level, but still it was increasing.
All right, thank you.
But the duration, well, yes, the duration of time between the end of the treatment and the relapse of the pain is different across the few patients.
It'd be worth just emphasizing the quality of the pain as well as
it's
sure. Okay, if there's no further questions, thank you so much, Roland.